First, I'd just like to thank everybody for inviting me here to talk again. Some of you may have seen some of the slides before that I'm going to show, but hopefully by the end of the day we'll talk a little bit about not just brachytherapy, but about some of the emerging treatments that we're doing at the Tom Baker Cancer Center for prostate cancer. I think it's nice to see a few people in the audience who haven't been here before, and hopefully this will provide a little bit of background on prostate cancer. So if you look on here, you can see that there's a lot of nice little slides, and then you see a picture of Tiger Woods there in the bottom, and you look and say, why would I put a picture of Tiger Woods on a opening slide? And the only reason that I just do that is, one is I think a lot of us here like golf a little bit, and we all strive to be the best that we can in whatever we do. Tiger has proven himself, and hopefully with what we're doing, we can prove that we're doing one of the best things for treating prostate cancer, at least here at the Tom Baker. Let's see if I can get this to work. So what I'll do is I'm going to try and go through this pretty quickly because I've got a number of slides, but a lot of them are images, so hopefully we can get through this in a reasonable time. For those that are new and haven't got a lot of information on prostate cancer, I'll just go a little bit into the background, and then I'll talk a little bit about what we see at the Tom Baker in terms of patient loads and what sort of treatment options we can give them. And then I'll go into the advances in treatment, what we're doing today and what we'd like to do in the future. So first, prostate cancer. Really, how bad is prostate cancer? I think we all know that it's one of the most common cancers that exist in men. In 2007, in Canada alone, there were about 22,300 men diagnosed, and approximately 4,500 will die from prostate cancer. That relates to about 430 prostate cancers diagnosed every week. Approximately 1 in 8 men will develop prostate cancer. And if you look at that and compare that to breast cancer, about 1 in 7 women will develop breast cancer. So prostate cancer is not that far behind. The biggest reason for an increase in prostate cancer has been the fact that since about 1987, PSA came into vogue, and as a result of that, people are being diagnosed a little bit earlier. There's more screening going on, and of course, the population in Canada is aging, and just like a lot of you here, you're more aware of prostate cancer, which is probably part of the reason why the incidence has really increased. What about in Alberta itself? If we look at cancer in Alberta itself, there's approximately 14,500 new cases of cancer, and approximately just over a third of them will die this is cancer in general, will die from cancer. So there's about 280 Albertans that will be diagnosed with cancer every week. Just over half of those will be men, and the rest will be women. But the bottom number is that about 50 or 100 people a week will die from cancer in Alberta. How does that relate to prostate cancer? Well, in 2007, there were about 2,500 men that are expected to be diagnosed, and about 430 die from it. That relates to about 46 men diagnosed weekly in Alberta. And if we look at it, 1 in 7, as we said, will develop it in Alberta. But 1 in 26 will die from it, and that's a big change from the past when it used to be a lot more. In Alberta, prostate cancer is the most common cancer that's diagnosed in men. So let's just look at the prostate anatomy and function a little bit, and then we'll move on. So what is the prostate? Okay, I think this... the computer seems to sort of zip through some of these slides a little bit faster than what I'd like it to do. But basically, it's divided into 3 zones, and if we look at it, you've got the little zone around the urethra, you've got a central zone, and then this peripheral zone, and this is the area where most cancers occur, which is why when you do rectal examinations, you can actually feel the cancer. The problem with prostate is that if you look at its location, it's located right below the bladder, just above the penile bulb, and just in front of the rectum. So no matter what sort of treatment you do for prostate cancer, you're going to affect these 3 organs. So what does the prostate do? Well, we really don't know a lot about what prostate function is, but one of the big things that we do know is that if we look at the seminal fluids or the ejaculate that most men have, it comprises about at least 50% of the seminal fluid. So if you take away the prostate, that's the one big factor that every man will experience. With surgery, because there's no tubes left anymore, there'll be no ejaculate. And after radiation treatment, the prostate will die out slowly over time, so the amount of the ejaculate will reduce. And why does cancer develop? Well, it simply develops because of a number of factors. One is that the cells can grow abnormally, or they can just refuse to die, or the cells invade into the tissues around the original structure, or that they spread to other areas, and the functioning of the cells, they can either increase or decrease depending on the type of cancer that you actually develop. So in prostate cancer, what are the risk factors? If we can break these into two groups. One is a personal risk factor that each man faces, and the second is the clinical factors, and these are the factors that affect the cure and the outcome, and the personal factors just affect the chances of developing prostate cancer. The three big things that affect it are diet, family history, and age. And for the clinical factors that affect how well you're going to do after diagnosis is based on the Gleason score, the PSA, and the clinical stage. So what about diet? Well, the only evidence we have is that there are some studies that show two factors only in diet. One is that a high-fat diet promotes tumor growth, not only in prostate cancer, but in other cancers also. But specifically in men and in prostate cancer, soy products actually help to reduce prostate cancer because they inhibit part of the androgen function of the cell. So high-fat diet, not good. High soy diet, good. What about family history? Well, if you have one family member involved, you double your risk of prostate cancer. If you have two family members involved, it not doubles, it quadruples. And when we talk about genetic predisposition of prostate cancer, we talk about the gene in prostate cancer that can cause prostate cancer. This only affects about 9% of prostate cancers. But to have this, basically you have to have at least 3 generations of prostate cancer, or at least 3 immediate family members involved with prostate cancer, or they have to be diagnosed at a very low age. The other thing with host-related factors, of course, is age. We know that if you're diagnosed early in life, that you tend not to do as well as if you're diagnosed later in life. There is some data that shows that black men will not do as well as Caucasian people, and this relates, some people say, to androgen levels and testosterone levels in these men that promote tumor growth a little bit more. So we look at clinical factors. There are the 3 factors that we looked at were, of course, the Gleason score. For those of you who do not know what the Gleason score is, it's the pathologist looks at the biopsy under the microscope, and what he does is he looks at the commonest and the second most commonest type of abnormality that exists. And he scores this from 1 to 5 in both groups. Then he adds these up to give a number out of 10. So if you score 1 to 6, you're considered to have a low grade or a slow-growing prostate cancer. If you have a 7, you're in the middle of the line. And if you have an 8 to 10, you have a high or a rapid-growing prostate cancer. And if we look at it under a microscope, a low grade looks almost normal with normal-looking cells. But in a grade 5, you can see here the big difference between the two, where the cells don't even resemble anything. And these are high-grade cancer cells that it doesn't matter what we do, people are not going to do as well with those with that type of cancer. What about PSA? Basically, PSA, if you have a PSA of less than 10, between 10 and 20, or greater than 20, it affects a little bit of what we do. And there is some data that shows that if you're diagnosed with less than 13 or higher than 13, it predicts somewhat in regards to systemic recurrence. Clinical stage is just when you feel the prostate, what you feel. If we look at a clinical stage of T1 and T2, it typically means that the cancer is confined to the prostate. And if you go to a T3, then the cancer is outside the prostate. So a T3 is considered more of a higher grade prostate cancer or a higher stage prostate cancer than the T1 or T2. So what we tend to do now, what we've learned from all this, is that if we group these three parameters into various combinations, we create three risk levels: a low, intermediate, and high risk. And what do we mean by that? Well, in the low risk, there's a good chance that the cancer is confined to the prostate gland. And this is usually people with a low clinical stage, a low PSA, and a low Gleason score. So in this group of people, it doesn't matter what you really do, the treatment is probably going to work. Whether you remove the prostate, whether you radiate the prostate, whether you do cryotherapy to the prostate, all should work equally well because the cancer is confined to the prostate. It's the next group of people that are the intermediate risk group of people in whom we think that the cancer is not just confined to the prostate, but may have escaped outside the prostate into the tissues outside. And this is where we're looking to see if we can improve treatment, and I'll be talking about this group as we go along. The high-risk group is the group in whom we already suspect that the cancer has gone to the bones or out of the region of the prostate, lymph nodes, tissues, anywhere else. Now, this can be microscopic at the time of diagnosis, so we don't actually have to see the cancer outside. But if you have any of these high-risk factors, like a high clinical stage where we feel the cancer outside the prostate, you've got a high-grade prostate cancer with a Gleason score, or a PSA that's high to begin with, chances are that this cancer has already escaped outside. So we need to be more aggressive and not just treat the prostate, we need to treat these potential cancer cells that have gone outside. So what is it that we do at the Tom Baker Cancer Center, and what sort of patients do we see? Well, in the low-risk group, where we don't see as many people as we probably should be seeing, we see only about 120 patients a year. Now, for this group, we offer brachytherapy or the seed implant almost exclusively to this group. And if we look at our cure rates here in Calgary at this point, we've been doing this for about 7 years. And at this point, over a 7-year time period, our cure rates are running at about 99%. We've had only about 4 out of 500 patients that we've treated that have had a PSA recurrence. So in other words, we're doing quite well with this group. The second group of patients we see are patients whom we see after surgery. We see about 150 to 200 of these every year, and some of these will offer external beam radiation therapy too, depending on some of the risk factors, and some will continue to observe and just monitor the PSA and offer them radiation as the PSA rises. The cure rates when we offer radiation therapy approach about just over 50 to 60% over about a 5-year time period. This is a group where we see about 250 patients a year. We offer them almost always external beam radiation therapy. A very few select group of these we may offer brachytherapy to. But the cure rates are only about 70 to 75%. And this is the group that I think we can do a lot better in than what we're doing at this point. The high-risk group are the group in whom we suspect, as we said, that the cancer is outside already. And we still see about 150 of these a year. Almost all these patients are offered external beam radiation therapy with hormonal therapy. Some are offered hormonal therapy alone if they're elderly or have other ongoing medical problems. And if the cancer is already outside and metastasized, then we may offer them palliative radiation therapy just to help improve symptoms that they're having. If there's no evidence of cancer outside at the time that we see these patients, with aggressive treatment, we can still get about a 60% PSA-free time period over 5 years. So we're not doing too bad, and comparing to 20 years ago, when we would see these patients, about 80% of them would be dead in 5 years. And at this point, we're now at about 60% are PSA-free. So in other words, we have improved, but we can still do better. So what about modern technology, and how are we using this to improve what we're doing? Well, the biggest advance in modern technology, of course, has been in brachytherapy. As we've shown that we have a 99% cure rate over a 7-year time period, And that's over 7 years, but probably if we extend that out to 10 years, I would expect that to be between 90 and 95%. Don't expect that it will stay at 99%. So I suspect that some people will still recur over the next few years, because that's the one thing with brachytherapy where we will see the failures, but they'll occur late. They won't occur immediately. The biggest thing is, can we do more for the intermediate risk group, and can we do more for the high risk group? So I'll go over a little bit about what we've done in brachytherapy in Calgary here, because we were the first people to start some of the modern technology for brachy, and it's now being used in a lot of centers across Canada as well as the US. And I'm actually happy to say that the technique that we're using was just picked up by Harvard University about 1.5 years ago, and by Memorial Sloan just about 1 year ago. And I'm actually working with Memorial Sloan on a project. So brachytherapy used to be done like this in the past. It used to be an open procedure where the surgeon would go in, and then the needles would be implanted from the abdomen, and then you'd have probably the resident's hand, not the staff's hand, of course, with the finger over there, because when you'd feel the tip of the needle, you know you've gone too far, right? So it's not my finger, it's got to be the trainee's finger. So why didn't that work? Well, it didn't work for this reason. Because the problem is, you really didn't know where the needles were going. And if you didn't know where the needles were going, you really didn't know where the seeds ended up. So obviously you didn't get a good dose of radiation. You would get a lot more side effects, and the cure rates were not very good. So that's why we don't like to be first in line with anything that we do. But we'd like to be like the second guy at least, right? Not way back in the back over there. This is what changed brachytherapy totally. In the 1980s was the invention of the ultrasound machine and the template-guided system that was initially started in Seattle. And by using an ultrasound in the prostate or in the rectum, you could see the prostate, and then you could guide needles into the prostate to place seeds. So what improvement have we made on that? Well, when this started in the 1990s, it was a pre-planned system in the sense that the patients were brought in a month in advance, an ultrasound was done, it was decided where all the seeds and needles would go, and then the patient would come back to the operating room, and then you would blindly put the needles into where you thought the prostate would be, and drop the seeds in. And it still works very well, because the cure rates are very good with doing that. But the advantage being in the 2000s is to do an intraoperative system where you bypass all that, you bring the patient to the operating room, and you do everything inside the operating room. And this is where we started, the first system in Canada to go with an intraoperative technique. And not only did we start with the intraoperative technique in Canada, but we actually advanced on further to a computer-guided system. So this is what used to happen in the past with the pre-planned system. You would map out the prostate on an ultrasound. You'd put up images inside the operating room, you'd try and match them on the ultrasound, and then you would use a template like this, as you can see here, where this is where the needle needs to go, and you would then advance the needle, and when you saw this little white dot, you know that you've reached where you want to be, and you could drop the seeds in there. But computers, as you know, have changed the way that we practice everything. The speed of computers has improved, the imaging has improved in computers, and because of that, we actually helped utilize all this in Calgary and develop this computerized image-based system. And what it allows us to do is do a 3D model of the prostate immediately in the operating room. We can then use this to create models that map out the needle positions onto the prostate, and then we can use these to guide the needles to where we want to go. And then we can use the computer to actually deliver the seeds. So in the operating room, we can set the patient up, and as you can see here, the ultrasound machine can be in place. We have the template here, we have a computer screen up here, we have ultrasounds here, and we have another computer in the back there. So what we do is the computer now will create a 3D model of the prostate within about 10 seconds using the ultrasound that we have. And we can actually then look at the prostate in all the different ways that we want. And once that's done, we can create a 3D model because we can map out the prostate in all the different dimensions, and we can map out the urethra, and we can map out the rectum, which helps us to guide the radiation dose that we want to give. We then have a computer system that in a matter of about 15 seconds, we'll do 500,000 permutations and combinations of where the needles and seeds should go to give the best radiation dose inside the prostate. And once that's done, so within about a minute and a half of all this, we can create a model where we can actually see the prostate, see where all the needles and seeds need to go. We can see the radiation dose around the prostate in all the different planes that we want. So we can ensure that the prostate is covered well. We can ensure that the urethra that's in the middle is saved so that the radiation dose of the urethra is not very high. And we can see here that if we limit the radiation dose around the prostate, the rectal dose will be actually very low. And then we can take the computer and it will then create onto our ultrasound machine a map of a needle where the needle needs to go. And then we can use that to guide our needle in place in a fashion like this. You can see this is the needle going in. And so we can continue to monitor that as the needle goes in. And then once the needle is finally in the right position that we want, and you can see here that this is the position where the seeds will actually drop, we can be more accurate on putting the seeds and needles in place. So if you compare this technique to this technique, I think there's a lot more visibility of what we're doing here than what we used to do back there. And this is the system that we actually developed here in Calgary. We then have this computer system, which connects onto the needle that we have. And inside here, we actually have the seeds and the cartridge. We have a drive wire here that will push the seeds and needles through the needle. Oh, sorry, this is not working as well as I expected it to. And so with everything attached on, we attach it onto the needle, and the seeds are then delivered directly into the patient. So everything is controlled here by the computer. The only thing that we do is put the needle in place using the computer map, and then attach on. The computer takes over and does all the delivery that we want. And as a result of that, we look and say, has this helped improve what we do? The big thing that we hope from this is that we make less mistakes. We just want to know what we're doing, as our little golfer over here. So what is it that we do here with brachytherapy? So the big thing is that if we look and see who we started this treatment, in 2003, and the patients that we treat are typically the low-risk patients, as we said at the beginning, and we do treat a very few selective intermediate-risk patients that have one of these intermediate-risk factors. The other thing is the gland size, and one of the other things that we developed here in Calgary was this mapping system for the prostate. If you go to other centers where they do the ultrasound technique, they will bring you in for an ultrasound and they'll try and map out where the pelvis is, and they'll tell you, well, no, the prostate is too big, we can't do your implant. What we can do here is we can do a CT and we can map out the prostate, the rectum, and the pelvis. And as you can see here, the prostate in this case doesn't fit. We cannot get needles into this part of the prostate because of the pelvic bones. So in this case, this prostate is too big for us to do an implant. But if the prostate looks like this, within the pelvic bones, that's a good prostate size that we can do an implant on. And again, that's something new that we developed here in Calgary. So you ask, well, why does brachytherapy work so well? And this is the main reason why brachytherapy works well. Not only do we deliver a high dose of radiation inside the prostate, but even if you've got low-risk prostate cancer, there's a chance that the cancer has already got outside the prostate, and 80% of the time it'll be between 3 millimeters, 90% of the time it'll be between 5 millimeters. And when we do radiation effectively, we can cover 5 millimeters of tissue with the full dose of radiation. So if this number holds true, then we would expect a 90% cure rate with brachytherapy, because we're treating this whole area of the prostate plus this risk group in which the cancer has already gone out. And you can see from the numbers that we've got so far, we've got a 99% cure rate, so we're actually doing better than expected. So the other big advantage of this technology has been that because of the computer guidance and planning system, where almost all patients get a very good implant in terms of the dosing. If we look at the side effects are much better than with a pre-planned system. And as we said, the outcome is excellent with only 4 out of 500 recurrences after 6.5 to 7 years. We've actually published this in one of the journals, the technique that we use here with the computer-guided system, and this was published just about a year ago in one of the brachytherapy journals. But like anything else, we have to be realistic and say that there's always a price to pay for anything that you do. I'd like to say that we don't have any side effects, but unfortunately, we do get a few side effects. If we look at urinary symptoms, severe urinary side effects are actually very rare. We've had only about 3 out of 400 patients, or 480 patients, that developed a urinary obstruction within the first few weeks after the implant, and 1 developed an obstruction over a year after the implant. We've had 1 person that underwent a TURP because of this obstruction within the first year, and 1 after 1 year that had a TURP done. And this is just a little bit of a reaming job where they go in and they open up the passageway so you can peel or you can void a little bit better. Now, if we look at our numbers here, they're very low, because if you look at the pre-plan system, about 15% of people will develop a urinary obstruction within the first week after an implant, and we've had less than 1%. And I believe that's because of the technique that we use with the guided system. The biggest problem with brachytherapy is what we call urinary bother symptoms. And if we look at the urinary bother symptoms, we can see that at 3 months, 70% of people have mild urinary symptoms, and about 25 to 30% have some significant urinary symptoms that may be bothersome. There's probably only about 5% of people that get severe urinary symptoms in the sense that they require some medications or treatment for it. And if we look at a year after the implant, 95% of patients are reporting minimal urinary symptoms, and only about 5% of people still have symptoms that are bothersome after 1 year. So in other words, the urinary symptoms are a bit of a bother, but they're not as bad as with the pre-plan system, where, as we said, about 40% of people get burning with urination that requires treatment with medications, where we get about 5%. And at about a year, we have 95% of people doing well with the pre-plan system. About 60% of people are doing well at about a year. The thing that's most bothersome to people, of course, is erectile dysfunction. Now, these numbers are preliminary at this point, and actually I've initiated a full study where I've sent questionnaires out to people to get better information as to how they're doing from an erectile function after brachytherapy. But the data that we've collected at this point from people coming back in and telling us how they're doing, about 75% of people that were not using anything prior to the implant are still able to have sexual function without any support. But about 23-25% of people do need some support, such as Viagra or Cialis or any of these medications afterwards. And we've had about 3 people that have reported that they're no longer able to get erectile function at all after an implant. And that's about an impotence rate of about just over 2%. If you were using Viagra before, almost everybody can continue on using it afterwards, and you still continue to function well, though we've still had 1 of those people that has reported being impotent now after his implant. But the bottom line with any erectile dysfunction is that there's always other factors involved in erectile dysfunction. So despite anything that you do with erectile dysfunction, there's always that little bit of added stuff that we all sometimes need, or people need to help improve things. Yeah, this would work, I think, at least, for me at least. So getting back to PSA, well, this is what happens to the PSA for all patients that have been treated to date, as we said. So the PSA, as you can see, tends to come down slowly. You get a big drop in the first year, but then after that, the PSA trickles down. But by about 3 to 4 years after the implant, your PSAs are almost undetectable or down to very low levels. And you ask, why does the PSA not come down quickly in this group? There are a number in whom it does come down quickly, but the biggest reason why it doesn't come down quickly is these people. When you average numbers, there's this phenomena called PSA bounce that occurs. And you can see here that PSA bounce can be quite significant. This is one patient in whom the PSA rose as high as almost 18 after the implant, but then came down, then went up and came down, and now, 3 years afterwards, his PSA is almost undetectable. And then this patient here, as you can see, his PSA sort of went up, came down, went up, and then came down. Didn't get as much of a bounce, but still sort of bounced around. So when you average all these numbers, you tend to get the numbers that sort of keep the numbers above what we would like to see at an average until they all are down at this point over here. What's the future of what we want to do with brachytherapy? Well, in Calgary, we want to be the first for everything. So about a year ago, we bought a color ultrasound machine through the help of Calgary people, because this money was donated to our prostate brachytherapy group, and with those funds, we were able to buy this machine. And we look and say, well, because we do real-time ultrasound and imaging inside the operating room, what we'd like to be able to do is say, can we target the cancer a little bit better? In a regular ultrasound, you can see that everything looks black and white. We really can't see where cancer is. But with a color Doppler, you can actually see here that the cancer is all located over here. And in fact, you can see here that the cancer is penetrated outside of the prostate. Now, we can do this mapping inside the operating room. We should be able to say, if we target this area a little bit higher with radiation, we may be able to do even better than what we're doing today. And again, if we look at another group, we can see here that on the ultrasound, everything looks black and white. You don't see anything. If we use something called contrast enhance, you can see, well, there's a little bit of an increased area over here. But with color, you can see that there's an increased area over here, and it's sort of an increased area over here. So you've got this area that corresponds with this, confirming that this is a high area of prostate cancer, and there's probably diffuse cancer spread out over there. So this is one of the things that we want to try and target inside the operating room at this point. And this is the project that I'm working on with Memorial Sloan, because they also decided, I actually presented part of this at a meeting in Austria last year. So they bought the same ultrasound machine, and when they started this implant. So we're combining together using color to see if we can do better mapping, not only for the cancer, but for the blood flow around the prostate, to see if we can evaluate that blood flow and improve even erectile dysfunction after treatment, because it's that blood flow that causes the problem with erectile dysfunction. The next group of patients I just wanted to touch base on before we, hopefully I'm not doing too bad here, is this intermediate risk group, because this is what we would also like to try and target a little bit better in Calgary. The treatment at this point for this group is you can have surgery or radiation therapy. We do have advances in external beam with IGRT and IMRT, but we can offer these patients a little bit more treatment now, because there is emerging evidence that high-dose rate brachytherapy works better than the external beam radiation therapy in this group. There is good data to show that the higher the dose of radiation you give this group of people, the better the outcome. With external beam, we've been able to increase the dose because of 3D conformal, IMRT, and image-guided radiation therapy, and we're showing better results by doing that. But with brachytherapy, if we add this onto external beam, we can even achieve higher doses of radiation treatment. This is an old slide, but it just again shows that as you increase the dose of radiation in this group, the amount of recurrences drops from 37% down to 19%. We've now increased the radiation dose to about 78 gray in this group, and the recurrence rates are now down to about 7% in people. This is within the prostate itself. In image-guided external beam, what we do is we implant 3 gold seeds inside the prostate, and this allows us, when we're doing radiation therapy, to map where the prostate is every day, and then we can adjust the radiation beam up and down, back and forth, to account for prostate position. This is just a little map of what happens in 3D conformal. So in 3D conformal, what happens is if we look at the prostate from here, this is just an image if we look at it, it looks this big, but from the side it looks this big. So what we can do is we can give a radiation beam from here that looks like this, and from the sides that look like this. When we add up all these radiation beams, what we tend to do is get a high dose in the middle and a low dose on the areas around. So in other words, we can shape the beams a little bit to the shape of the organ at that point. in IMRT, what it allows us to do is inside the external beam machine, we can put these little blocks. So we can see that if we want to put less radiation over here, more radiation over here, we can vary the size of the blocks, or we can do this with a different technique. But again, it's something similar to achieve this. And when we do that, we tend to get a higher dose of radiation in this line and in this line, and a lower dose of radiation there. So when we add up all the beams, what we tend to do is we tend to be able to create a higher dose of radiation in this shape, a lower dose in this area over here. So the difference between the two is that we tend to get an even dose of distribution here with 3D. Here we can vary the dose a little bit, but the problem of doing this is that we tend to get a bit of a higher dose in the tissues around the prostate because we've conformed the dose inside the prostate a lot more there. The problem is that despite doing all that, we still cannot achieve as high a dose as we really want inside the prostate because of the limitation of the bladder and the rectum that exists there. So what is a better way to deliver a higher dose inside the prostate? And that, of course, is by using brachytherapy or seeds or putting a high dose of radiation directly inside the prostate. So what we're looking at developing here is something called an HDR program, or a high-dose rate brachytherapy program. And in this sort of brachytherapy, instead of the seeds where you put the seeds in and the seeds stay for permanently, and the radiation is delivered over some time, in the high-dose rate, we give a high dose of radiation immediately to the prostate, and then we remove the source. The problem in the past has been that to do this required hospitalization, required that you needed to have catheters put inside the patient like this, and the patient had to lie in bed with catheters like this sticking out of him for about 2 to 3 days because we could not deliver the radiation dose safely at one time. It had to be still split up over about 2 to 3 days depending on the number of treatments that you were doing. It does look like seeds in a way because, again, you can conform the radiation dose around the prostate, but instead of having seeds, you have these needles that are sticking out over here. And what those needles do is they attach onto a radiation treatment device over here, which then pushes a radiation source through each of these in turn to develop a radiation cloud around the prostate that looks like this. So again, we can create a high dose here, and you can see that you can protect the rectum on the bottom and the urethra in the middle. So what about comparing these two systems, HDR and the low dose rate, and what are the differences between them? With the low dose rate, the advantages are that there's a lot of worldwide experience in using this. There's well-known outcomes, it's a single treatment, and we know that the low dose radiation works for quite some time before it dissipates. The advantage of the high dose rate is that everything is delivered very quickly. So it's delivered over about 15 minutes. There's no post-radiation safety issues. And the big thing here is that we can treat higher risk patients with this form of therapy. The disadvantage of low dose rate is that, one, again, the treatment is delivered over a year, which can be an advantage or a disadvantage. There are radiation safety issues for anybody who's had brachytherapy. I'm sure going through airport security sometimes may not be the most pleasant thing to do. But these days, at least because most centers are geared up for this, they tend to ignore people with seed implants because they can actually tell what type of radiation you've got. And the big thing is that it's not good for rapid growing tumors, because in a rapid growing tumor, the tumor can double. Let's say it can go from 1 to 2 cells in 2 days. But if the radiation is delivered over 3 days, then the cancer cell has already doubled before the radiation has been effective enough to kill that cell. So it's good for those cancers that are growing slowly, but it's not good for the cancers that are growing rapidly. The disadvantage of this is that it's typically used with external beam. Now there are long-term results emerging, but there were not good long-term results in the past. And of course, the big thing is whenever you're developing something new, there are not a lot of centers with experience, and the dose was not well determined. Though that is all changing as of now. And basically what's happening now is that with modern and new technology, you can get away with a short course of external beam radiation therapy of about 3 weeks, and then one single treatment with HDR, using an ultrasound-guided implant almost similar to what we do for the intraoperative low-dose rate brachytherapy that we're doing right now. And if we look at this, what it simply shows, and don't take anything more from this, is that with external beam, if we look at the radiation effective dose, it's about 165, but with a brachytherapy boost, we can boost that up to about 214, and in fact, actually, we can even go higher to almost about 250. And as you saw with that table that I showed you, as the radiation dose increases, the cures are getting better and better and better. So with this system, we can actually give more radiation dose. Now, I'm just going to flip through this, and I'm just going to show you this, because with the old way of doing HDR, it required all this system that patients had to go through. So patients had to go through all these multiple steps, and even as a radiation department, we had to go through multiple steps of transferring a patient to another area, sending images off to one center, doing contouring on a different computer, trying to bring everything back, and then delivering the radiation, which took almost about 3 hours to do one single treatment. But with the development of an intraoperative ultrasound-based system, which has now been developed but is not being used anywhere in Canada yet, you can actually do it all at one time, and we can do the whole treatment within less than an hour. Actually, this is faster than the low-dose rate treatment. And again, you can see here that the dose of radiation can be conformed well around the prostate, protection of the urethra, and protection of the rectum. So why would we want to do this? Well, we want to do this because, one, is that we want to improve treatment for these patients with intermediate and high-risk prostate cancer, and because evidence is now emerging that this is becoming an effective treatment. These simple slides show that, again, if we look at external beam alone versus external beam and brachytherapy here, almost 100% of patients are cured at this point, versus with external beam alone, there are about 40% of patients recurring. In this slightly higher risk group, again, external beam patients and external beam and brachytherapy, the brachytherapy group are doing better than those with external beam alone. And in the high risk group, still, the people with external beam and brachytherapy do better than with the external beam alone. And because I'm working with Memorial Sloan, I do have some data that it's not been published yet, but is about to be published, that using the high dose rate, they can actually, because they've got the longest experience with high dose actually in North America, that better PSA control, better clinical control. But the most important thing that they're now showing is that if you use brachytherapy and external beam, people will actually live longer than getting external beam alone, which I think is the biggest reason to move ahead with it. And basically their slides show that, again, if you use the brachytherapy and the external beam at 5 years, you can see here that this group of patients, almost 90% cure. Here, you're down to only about 70%. If we look at clinical failures, that means people with metastatic disease, again, better improvement than if you do a low dose or just the external beam alone. And survival has been the big thing, where again, at 5 years, almost 99% of people are surviving, versus in this group, 80%, but down at 10 years, you can see that this is down to about 65%, and the brachytherapy with an external beam are doing much better than that group. So the biggest advantage of this, I think, is that it will allow us to treat both intermediate risk patients with less treatment time, less movement of the patient using the ultrasound-guided system. And even for high-risk patients, we can offer them this treatment. And the biggest thing is that the treatment time is much less. I mean, you heard somebody say that when they got external beam, it was 7 weeks of external beam. Today, if you get external beam, it's between 8 and 9 weeks of external beam radiation therapy. Versus with a combination of brachytherapy, you can get away with 3 weeks of external beam and then one implant inside the operating room. The other big advantage is the hormonal therapy, where people have been on it for 3 years. We can reduce this down to 1 year. The side effects that are being published so far show that the urinary side effects and erectile dysfunction rates are no different than if we look at the low-dose rate brachytherapy group itself. So at this point, we do have a bit of roadblocks in trying to move ahead with an HDR system in Calgary. And mainly it's because of a combination of funds and training. But we are working with the Alberta Cancer Foundation to see if we can procure some funds to allow us to obtain some of this equipment and then try and be the first in Canada to start using this treatment and to offer this treatment to people that I think deserve it. So basically the last slide is just to show that in this, as a summary of what we've been able to do at the Tom Baker is that we've made a big improvement in our low-risk patients by offering them the seed implant brachytherapy with a 99% cure rate at 6.5 years at this point after treatment. And we're continuing to try and improve this with the advent of color ultrasound inside the operating room. We would like to really do more for our intermediate risk patients. We have done a little bit with the image-guided radiation therapy, which has allowed us to increase the external beam radiation dose. But despite that, we're still only looking at about a 70% PSA-free survival at 5 years. And we'd like to get that up to about 80 to 90%, as we can see with the combination of brachytherapy. And in the high-risk group, there are still a lot of things that we can do to try and improve this. But at this point, we are looking at a combination of HDR or potential chemotherapy in this group. And there is a study ongoing combining chemotherapy along with the external beam to see if we can improve the outcome for this group of patients.
Time for a few questions?
Sure.
Sure. Any questions here from the doctor?
I would like to thank you and express my appreciation for the great work that you're doing. I leave here tonight inspired, and I know we're looking forward to attending this meeting. So I want to congratulate you. I'm just a little, but I offer you my feelings of gratitude from the bottom of my heart, and I thank you for the good work that you're doing. So thanks a million.
Thank you.
Any other questions?
Dr. Husain, you talked about the number of people you've treated since the start of the Tom Baker.
You mean brachytherapy?
Yeah.
Yep.
Yeah. How many are you treating on an annual basis?
At this point, we're limited to treating about 80, between 80 and 90 patients a year, and that's based on restrictions from the Alberta Cancer Board. But now that the Alberta Cancer Board is gone, and we're now working with the Alberta healthcare system, or the AHS as we want to call it, we've applied to see if we can get an extra day of operating room time, because right now our waiting list for brachytherapy, unfortunately, is fairly high. We're booked up right until almost the end of January, and I think at this point, if we see any new patients, we cannot offer them brachytherapy until about February of next year. So that's our waiting list, and so we really are working with the AHS to see if we can get an extra OR day per month to at least treat more patients.
Right.
Dr. Husain, I have two questions for you. The first has to do with separating the rectum from the prostate. In certain techniques, certain therapies, especially cryotherapy, they inflate the area between the two and separate them so that the cryotherapy does not freeze the rectum. Are you thinking of doing that with your high-dose radiation?
No, the advantage that we can do with brachytherapy is that we can tailor the dose. So what we do is that if you look at some of the images, on the sides of the prostate, we can push the radiation dose out because we know that that's where the cancer extends. We know that the cancer doesn't come out in the bottom part of the prostate, between the bottom of the prostate and the rectal area. So we actually take a very small margin around the prostate in that area to protect the rectum. And because we can calculate everything quite effectively and efficiently, we can ensure that that happens. And that shows in the results of so far. With brachytherapy, we don't get any rectal side effects. It's very rare to see anybody with any rectal symptoms at all. May get a little bit of loose bowel movements for a week or two after the implant, but after that, almost no symptoms. We've not seen anybody with rectal bleeding related to the implant, and most centers will not get that at all. Versus with cryotherapy, the problem is that they can't tailor the freezing around the prostate as well. So whatever margin they're creating on the sides, they have to take on the bottom. And as a result of that, they do want to increase the distance between the rectum and the prostate. So it's a difference in technique and tailoring of the dose.
Could I clarify, you're not giving high dose short-term radiation at the present time?
No, we're not doing that. It's a high dose rate. And what that simply means is in the low dose rate, when we say low dose rate, it's like you heard me say the radiation is given off slowly, and it takes almost a year for the radiation to fully come out of the seeds. Versus with a high dose rate, all the radiation dose is delivered at one time, like in those 15 minutes that we allow the radiation source to be there. And then after that, there's absolutely no radiation. So when a person goes home after that HDR or high dose rate brachytherapy treatment, he doesn't have to worry about radiation safety issues. He doesn't have to worry about children, pregnant women, or anybody else. It's just like having external beam where the radiation is gone after you've left the operating room.
And you're not doing that yet?
No, we're not doing that yet. That's the program that we would like to really start at this point in time. And as you heard me say, because of all the emerging evidence of its benefit, it's the next step in our evolution of treatments, should we say, in Calgary.
Could I go off on a different tangent?
Sure.
I'd like to pick your brain while I can.
Sure.
My interest is
have one, but
my interest is advanced prostate cancer, bone mets, etc. We hear a lot about strontium injection, radioactive strontium. What are the disadvantages of it, and why is the medical system so reluctant to give it?
well, I mean, I actually do use strontium, not that often, probably once or twice a year. The problem with strontium is that you can't really direct where the radiation is going to go. It is something that's picked up more exclusively by the bone marrow, so it goes everywhere in the bone marrow. So if a person has a lot of extensive disease inside the bone marrow, the problem is that you'll have so much uptake of this strontium into the bone marrow that you could effectively kill all the bone marrow. And if you do that, not only are you going to kill the cancer cells, but you're going to disrupt your whole immune system. And just like people who have transplants where you destroy their bone marrow and then try and give them a transplant afterwards, you would have to do something similar because you destroy their entire bone marrow, which would put them at risk for infections and all the other risk parameters associated with that. So there's a problem in that if you've got too much disease, we can't do it. If you've got too little disease, then we can do much better treatment with external beam, because the external beam will work very quickly, and pain management, or if you're having pain because of metastasis, the pain improves within about 3 to 5 days after giving external beam radiation therapy. With strontium, it takes about 2 weeks to start seeing an effect of the radiation, because even though the radiation is taken up, it is distributed slowly, and its effects occur over a short time period. So you're still looking at about 2 weeks to see an improvement. So as a result, if you've got small volume disease, we can do better with the external beam. If you've got a high volume disease, then it's too risky to give the strontium. So you have to have disease that's a little bit in that middle, where you've got a little more sites than what we can do effectively with external beam, but not enough that by giving strontium we'd overdose you. So that's part of the biggest problem in using strontium, and the main reason why it's not used as much is for that main reason.
Thank you.
One final, this gentleman.
It's probably the best question because your success rate is so good. But if you have brachytherapy done and for some reason it doesn't work, what are the options? Because like a urologist said, it's a radiated prostate. There's nothing they can do about it.
Yeah, that's always a good question, because I know it's a common. I think 20 years ago, it was a big factor, because if you saw the numbers that I showed you with the radiation when we increased the dose of radiation, those numbers of using 60 gray were back in about the late 1980s, early 1990s. And at that point, recurrence rates inside the prostate were as high as 30 to 40%. So if you got radiation treatment, it was true that you could really not give radiation again, And if the recurrence occurred inside the prostate, you were actually doomed because there wasn't a lot of other options for treatment. Hormonal therapy didn't exist back then, but as hormonal therapy became available, that became a treatment that you could only offer people after radiation failure. The advantage of modern technology is that, as we've shown you, that the higher the dose of radiation, the less recurrences we see inside the prostate. With brachytherapy, the radiation dose is so well tailored around the prostate that in that rare event where you may get a recurrence inside the prostate, and to date there have been in Canada, there are about 5 or 6 recurrences that have occurred out of the thousands of people that have been implanted across Canada over the last 10 years where recurrences has occurred inside the prostate. And one center in Toronto is still doing surgery on these people because the radiation is so well tailored around it that the tissue margins are still accessible and visible to the surgeon, so he can go in and still remove the prostate. And in the 5 patients that they've removed the prostate in Toronto, they've done fairly well. The biggest problem to think about, though, is that when recurrences occur, where do they occur? The 10% of patients that you heard me say that potentially are going to fail after brachytherapy are going to be because the cancer is outside the prostate. And if the cancer is outside the prostate, then surgery is not an option anyway. And at that point, you need some other systemic form of therapy. So the bottom line of what I'm saying is that 20 years ago, the surgeons were very right in saying that after radiation, you could not get surgery. But after brachytherapy, today you can get surgery. After external beam, though, you still cannot get surgery afterwards because the radiation melts all the tissues around the prostate, so the surgeon cannot differentiate the rectal wall, the bladder very well. And so if he was to go in and try and remove the prostate, he would cause too much damage to your rectum and bladder that wouldn't be a worthwhile treatment. But with modern technology and the way that we're doing radiation, we rarely see recurrences inside the prostate. Maybe about 5% of people recur inside the prostate after external beam. And at this point, you heard someone say that they got cryotherapy. Cryotherapy is still an option for these people if they get a recurrence inside the prostate. Or hormonal therapy is the other form of therapy that you can use for these people. So I don't know if that answers the question, but hopefully it clarifies it a little bit.
One quick question.
I just wanted to know, once a patient has started the therapy, hormone therapy, can the prostate still be removed after they start the hormonal therapy?
Absolutely. There's no reason why not. In fact, it used to be a standard form of therapy for people with intermediate risk disease a number of years ago, where they would give hormonal therapy first and then do surgery 3 or 6 months afterwards. But in all the studies that were done trying to compare giving hormones first and then surgery versus surgery alone, there was no differences amongst the two groups. So most of the surgeons do not use it, but that doesn't mean to say that you cannot have surgery after hormonal therapy. By all means, anybody can. It doesn't affect the prostate in any way.
Okay.
Okay?
Thank you, Siraj.
All right.
Really appreciate you coming out.
Sure.
And we
Great.
support your efforts.
Oh, well, great. Thank you.